Hey, it's Miki again, and we've got another hand question in our series of questions for medical students, residents, and fellows taking the in-training exam and the boards. A 24-year-old male presents 1 year after a radial nerve repair with persistent wrist drop and inability to extend his fingers or thumb. Which transfer is not an option for this patient? A. Palmaris longus to extensor pollicis longus. B. Flexor carpi radialis to extensor digitorum communis. C. Pronator teres to extensor carpi radialis brevis. D. Extensor carpi radialis longus to extensor indicis proprius. And E. Flexor carpi ulnaris to extensor digitorum communis. Here's your chance to pause the video so you can answer the question. A radial nerve palsy is a devastating injury to the function of the upper extremity. And if you're 1 year out, it is unlikely that the nerve is going to return at this point in time. The classic transfer to restore hand function, the palmaris longus to extensor pollicis longus, flexor carpi radialis or flexor carpi ulnaris to extensor digitorum communis, and pronator teres to extensor carpi radialis brevis. So to restore wrist extension, the pronator teres, which attaches or inserts into the radial side of the midshaft radius, is peeled off because the tendon there is very short. It's literally peeled off subperiostally and then attached to the extensor carpi radialis brevis. And it can be done an end-to-end repair, or you can do an end-to-side repair. To restore extension of the fingers, the extensor digitorum communis tendon is transferred to the flexor carpi radialis or to the flexor carpi ulnaris. To restore thumb extension, the extensor pollicis longus tendon is transferred to the palmaris longus tendon. If you look very carefully at these transfers, the pronator teres, flexor carpi radialis, and palmaris longus muscles are all innervated by the median nerve. Hence, a radial nerve palsy should not affect those muscles, and those transfers should allow for restoring of function of wrist extension, finger extension, and thumb extension. So the answer to this question is D, extensor carpi radialis longus to extensor indicis proprius. So the extensor carpi radialis longus cannot be transferred to the extensor indicis proprius to restore function because the extensor carpi radialis longus should be denervated and should not have any function because of the radial nerve injury. Thanks for watching. I hope you learned something, and please subscribe and like so you can keep supporting this channel.